Senator? Oh, okay, great. So-
Welcome to AT&T's teleconference service. Please enter your access code, followed by the pound sign. The host has not yet arrived. Please stand by. Billy, please continue to hold.
What's the host code? Do we know about Celia or Mary Popkin? Heidi, do we know where DA Sparks is?
Welcome to AT&T's teleconference service.
She's gonna be here for Ledge Day, so something must be up.
Okay.
There are 2 participants on the call, including you. You are joining your conference as the host. For a menu of available commands, press *#.
Thanks so much, Gwen. Good morning. Colette Peters here. Who do we have on the line with us today?
Trevor Belts from Senator Bates' office.
Thank you, Trevor, for joining us. And who else? Okay, they said there were 2 people on the line.
Including you.
Oh, pardon me. Okay, with that technical difficulty and misunderstanding, I'll pass the gavel. Thank you, everyone, for joining us this morning. I am pleased to note that we have another very full agenda, but I promise that we will end on time today. We're scheduled to adjourn at 11:30. The first agenda item this morning is responses to all of your requests and questions from the last meeting. And I want to thank our health services folks for working diligently over the last couple of weeks to get those responses in order. And Mr. Hafel, if you want to come forward and walk us through those questions and those requests.
Good morning. For the record, I'm Bill Hafel, Health Services Administrator for the Oregon Department of Corrections. Thank you for letting me come back to speak before the work group and look forward to participating in these conversations in the hopes that we can find some savings. The information requests that we got out of the last meeting, questions were around the numbers we have currently in hospice. And as you can see, well, go ahead and go to the next slide. The locations are where we have hospice beds and current hospice patients, the penitentiary, Eastern Oregon, and Two Rivers. So we have a total of 3 patients in hospice right now. We have hospice available at 5 facilities, and those are the 5 facilities that have infirmary level care available. There was a request for data around catastrophic injury and events. Fortunately, what you're looking at is a lot bigger than what I'm looking at, so given my advancing age, I'll get my glasses. As you can see, 2 of these, they're all as a result of assault. 2 of them ended up in death. And that's basically, those are the numbers. You can see the date range. Okay, moving on. There were questions about the mental health co-occurring disorders. More than 450,000 Americans with a recent history of mental illness are incarcerated, either in jail or prison. 24% of those, 24% are in prison, 21% in local jails. Of these, approximately 72% have a co-occurring substance abuse disorder. By comparison, about 6% of the general population in the country has those concerns.
So what does it look like for us here in Oregon?
Well, we don't have statistics on the non-incarcerated population. We only have statistics on the incarcerated population.
incarcerated.
Yes.
So what does that look like?
47% of the men have a mental health diagnosis, 78% of the women.
47.
Substantially higher for
Substantially
women.
higher for women.
Sheriff Garrett had requested information on health costs by age over a 10-year period, and unfortunately, we're only able to retrieve that data since 2009 when we went to the new third-party administrator, because we get a much more sophisticated suite of reports than we got previously. So we do have 4 years of data. And what you're seeing on this slide is just off-site healthcare costs. We don't have an electronic health record at this time, so we would literally have to do a search of every inmate's health record in order to collect that data. But I think, as not unexpectedly, and as you can clearly see, 46 to 60 and 61 and over are clearly the most expensive age categories for us. Continuing with off-site data and cost per inmate, this one's a little difficult, so I'll explain how we did this, and I'm not sure it's the most effective way, but it was kind of the only way at this point we could do it. So on the left-hand chart, what you're looking at are the costs for off-site care only in 05, 07, 07, 09, 9/11, and 11/13. The chart to the right includes the per inmate per month cost. That's over the entire population. We would had to have done a different kind of data sort and hand calculation in order, because they're not unique patients. We could use our off-site encounter numbers, which is somewhere over 6,400, but those are sometimes the same patient over and over again. And we'd have to sort through those last two biennia and all the patients in order to figure out which ones had gone multiple times to reduce how you get to the per inmate. If you'd like us to collect that, we can do that. It's just going to take us a while.
What were the components of those costs if you unpacked it? For instance, pharmacy versus direct care.
This is all off-site direct care costs. The pharmacy we do internally. This is hospital level care. It's appointments with specialists. It's follow-up with specialists. It's labs.
So only those things that we don't have the capability of doing.
So when they're off-site, you supply the medication when they're off-site?
No. So in a hospital, if they're prescribed something, that's included with the hospital cost.
Okay.
Mr. Havel, can you talk about the flattening of the costs? Because I think that really tells the story about when
Okay.
the third-party health administrator came on. So you can see it was climbing almost straight up, straight through the roof. And we were projected, if I remember correctly, to increase our
20
healthcare costs
20,
by...
what the previous third-party administrator had put on letterhead and sent forward to DAS was we should expect, given the population we serve, that we should see a 20% per year increase over each of the next 5 years. And clearly, we felt that's not sustainable, and did not want to go before a legislative committee and say, you're going to need to double our budget in 5 years. So we began working with that third-party administrator to try and get more efficiencies. We felt we didn't get where we needed to, so we went out for a request for purchase. We ended up selecting a new third-party administrator who began in July of 2009. So what you see there, we did do better from 7/9 to 9/11 than we did in 7 to 7/9. But we still saw roughly, we flattened it to about 10% over 2 years. And now it's down to around 8% over the 2-year period. And part of the reason for that is a much more aggressive claims management and bill review, but also the quality of the network that we have with the discounted rates. It's through First Choice Health, who our third-party administrator contracts through. But we have their nurses in the hospitals actually seeing patients, checking on patients, and we have a daily telephone call Monday through Friday with CHP, Correctional Health Partners, their medical director, their staff, our staff that have patients in the hospital, and our medical director talk about the prognosis for the patient, what's going on with them, how quickly can we get them out of the hospital, is there any kind of a piece of equipment or something we need to get them back into our care, because they're not going home to home care. They're coming back to basically a skilled nursing facility. So anything we can do to expedite them getting out within medical constraints, we're doing. We've tried to bring more services on site, which doesn't directly impact our budget necessarily, although it does save. If we're able to bring the service in, sometimes we can get it cheaper than we do sending it out. But it does save transport costs. Obviously, every time one of our offenders goes out into the community, they're escorted by security staff. So we're trying to minimize that as much as we can. Bringing dialysis on site is less expensive than having to transport off site. So partly, the volume of catastrophic offenders and their costs ramped up more slowly, I think, this biennium, and I think we talked last time, to some extent, I think we were a little bit lucky until the end of the biennium, and it always tends to level out, and probably the last 6 weeks of the last biennium were some of our most expensive weeks. We had some seriously ill people. We've implemented a chronic disease self-management program where we're trying to teach offenders how to care for themselves, how to recognize symptoms and when they need to seek medical attention, but how to live better and smarter on their own, and teach them about what long-term consequences are about not dealing with their disease. With that, we're trying, from the internal side, we're doing a pilot at OSP right now where we've tasked a nurse specifically just to deal with the chronically ill population, to make sure they're getting seen, to make sure their labs are being drawn, that we're reviewing the results. As I'm sure you can imagine, let's take the Oregon State Penitentiary, for example, a somewhat archaic facility, particularly if you've not been there. The infirmary and healthcare area is on the 3rd floor, serviced by an old elevator. When the power goes out, if we have a medical emergency, we backboard a person down the stairs. Not the best of all worlds, but they do a good job. But without an electronic health record, with an antiquated facility and an old environment the way it is, they do the best that they can, but things get missed. And so we decided to target those resources towards providing care for the chronically ill. And what we've seen just in the first month, we had 2 patients, diabetic, insulin dependent, who refused to take insulin. And through that nurse working with them and educating them, we got them into the chronic disease self-management program. On the educational side, the nurse worked with them. They are now both cooperative, and their lab values are within range again. So, those are the kinds of things we view as a success.
The last meeting that we had talked about the individual that you have that has about a $47,000 a month pharmaceutical cost, and that there's only one pharmacist. Is it possible, and we get, of course, no match for that person, because, you're... What kind of relationship if we were having that person with OHSU, because they qualify for the 340B kind of program, or have you looked at that? I'm just trying to think in terms of where we have individual or entity where the cost is exorbitant. In this case, when you start talking about almost $50,000 a month, is there some way that we can link with OHSU, and then at least we're doing 60-40 or whatever the split is, rather than the 100%?
We approached that earlier this year, around 340B pricing with OHSU. We were originally working with the manager of the outpatient pharmacy, and then began working with that person's supervisor. And in the end, what we were told is they didn't see any way for that to work at this time, that all the 340B programs are under intense scrutiny from the feds. There was a specific intent for 340B, and corrections is not part of that population that they serve. So at this point, we do, because of is it our hemophiliacs?
Yes, correct.
Yes, for hemophiliacs, and our HIV patients do see a physician that then follows them into the community. So in certain circumstances, we can access if they're being carried as a patient by them. But otherwise, our staff would basically have to be on staff at OHSU, or an OHSU physician would have to be seeing them.
Is there something, and you said that not at this time, is there something that we should continue some conversation with OHSU? I mean, when I'm looking at, and I think all of us as legislators, when we heard that almost 50,000 a month, we're going, is there some way that we can actually reduce that bill? So hopefully the conversation didn't stop with OHSU, that there is maybe some way that we can do the
Well,
340B
the
pricing?
second part of that response to us was, and even if we were to sell you the drugs, you're not getting them at 340B pricing, because the purpose of that program was for them to get low prices, lowest pharmaceutical prices, and to sell them at a higher rate to help fund other care within the hospital for the poor. So at some level, the response was, you're not going to get it at 340B pricing, even if we could figure out a way to supply you.
We would damage the
You would
program.
still get some significant markup.
So another question, what kind of conversation have you had with the pharmaceutical company itself? Because I understand it's only one,
Correct.
With MCAP?
yeah.
No, if I understood correctly, you're talking about the manufacturer of the medication.
Oh.
Yeah.
Because sometimes they'll be a little more, they'll be somewhat benevolent, and particularly where you've got a long-term, and so since it's the one, what kind of negotiation or discussion has been held with that company?
We will ask, at this point in time, the company's not been very willing to, they're
If you
not
need-
entirely cooperative. It's a very rare medication. It's Synzyme. It's a very rare medication for a very rare condition, and they're not much in the way of, this is the medication, if you're going to take it, here's the price.
Well, let's talk offline, because sometimes we can be helpful.
Okay.
Great, noted. Director?
Bill, I had a question. I want to jump forward for a moment to the Pew report. As far as the cost, it looks like you've been doing a much more effective job controlling costs for the past 7 years, because as I looked at the Pew report, in that 7 or 8 year period between 2001 and 2008, the cost jumped by 245%, and you've done a much better job managing it within the past 7 years. What are we doing differently?
Well, thank you, and that would be great if that were actually accurate. So I'll just, do you want me to just jump in, or?
What I will say is, we put, the Pew report came out following our last meeting, and there was some data points in there that startled us. And so we did an analysis, and some of the data that appears in this report is not accurate. So we dedicated some time on the agenda to walk you through
Right.
that following this presentation, and we'll do that. But I think to your point around what you've been doing differently includes things like engaging with a third-party healthcare administrator, our pharmaceutical purchases, managing chronic disease.
Right. I mean, 92% of the prescriptions we fill are filled with generic medications. The last article I read was that even out in what we'll refer to as the real world, it's somewhere around 84%. So, that is the first, not that the other drugs can't be accessed through the formulary, but your starting place is going to be the generic if it's available.
Thank you.
So we provided a copy of the suite of reports we get from our third-party administrator, which includes outpatient and inpatient data, denied bed day savings. So they're very aggressive about if there are tests performed or services performed that were not authorized or we believe not necessary, we challenge the payment for that. And then if we've paid for something or they billed us for it, we either don't pay for it or we recover the money for it. There are dashboards and then reports on readmissions as well. And while it's there's a lot of information in there, so if you get an opportunity to look through it and have questions, we'd be certainly happy to answer any of those offline. You can email us or however you'd like to do that. The percent of total population requiring special health care, this graph we talked about at the last meeting. It shows some of the more serious health issues facing the inmate population. Obviously, hepatitis C, respiratory, and cardiovascular issues continue to rise. Number of inmates with diabetes has increased 48%. And while the numbers are small, HIV/AIDS has increased by 17%. So the bar graph just shows the degree to which we're seeing more inmates with serious illnesses. And then,
Havel,
yes,
is that based on costs, or is it based on numbers of episodes?
it's based on diagnosis.
Numbers of diagnoses?
Numbers of patients,
Number
yep.
of patients, okay.
Yep. And then, is this, okay. So one of the questions we got was, what's it look like, I believe from Sheriff, was, what's it look like per thousand? And so we got our map hats on and did that. So this will show you what it looks like over time since 2006 to 2012 in cases per thousand.
Thank you.
You're welcome. Okay. We may be missing one piece of information from a question you asked, and we will get that back to you.
Okay, and I greatly appreciate that.
Okay.
Thank you.
So are there any questions about what we've talked about? Yes.
Yeah, thank you. Thank you, Madam Chair. When you look at cardiovascular disease, what determines that somebody is being diagnosed with that? 350 people out of 1,000, what's the determination? Is it high cholesterol or?
I can't answer that for you. I'm not a physician, but we can get that answer for you.
Is it fair to say that it would be the same diagnosis in the community?
As in the community, yes.
Okay, but we'll
yeah,
get the
I'm wondering what
specifics.
that is, because if somebody's on Lipitor, does that mean they have cardiovascular disease?
Not necessarily.
Not necessarily.
Could be prevented.
350 per 1,000, that's,
I can understand your question. That
Okay.
seems high.
thank you.
I have one comment. Is it possible, some of this data, to me, I can't read it.
Okay.
Is it possible to have this reproduce
For
so
the
that we can
chronologically
read it?
advantaged group.
Absolutely, and for the next presentation, what we can do is ensure that we don't do the small
Yeah.
slides, we'll do the big slides. Now, I believe I'm correct that you all received an electronic version of this on late on Friday.
Yeah, that's
Representative Cameron, to back up to your observation, and assuming that the diagnosis is the same as it is in the community, I think one of the things that we see when we walk through the prisons is an unhealthy group of individuals. And these are individuals who haven't received preventative care. They're 10 years older biologically than their chronological age because of the lifestyle that they've lived. And so that statistic doesn't surprise me, as shocking as it might be. It's unfortunate. One of the suggestions that was made by Representative Williamson last time was that we looked at the nutrition that we're providing in-house. We often talk about reducing food costs and not necessarily focusing on the
Long-term costs.
what we're paying in the long term, absolutely. And so I believe we've noted that as one of the recommendations from this group.
Also, prior drug use, depending on the drugs of abuse, since you have a high population of drug users, particularly the amphetamines will cause cardiac problems. But diet and lack of exercise are large contributors to the profile that you're seeing, I'm pretty sure.
Thank you. All right, any other questions?
I would just add, my 1.5 magnification is not quite getting to the small print as well. So I appreciate you sent them out earlier. The 3-to-1s are just a little over the top for me. 2-to-1s would be great, a little bigger.
Great.
Thank you.
Okay, seeing no other questions from Mr. Hafel on the responses to the requests from the last meeting, we will turn your attention to the Pew Report Managing Prison Healthcare Spending. Mr. Hafel.
So how timely was this
It
report?
must be online.
And it should have been attached to your email. Did we bring copies? Okay. Apparently, I'm the only one with the copy. I'm happy to share.
And I wasn't, I've been
Actually, I
away.
have a
And you've been
copy,
away?
too, for
Great.
some reason. I don't know
So
why.
if you just want to give an overview, and then
Thank you.
please know as you're going through this, if you have questions later, don't hesitate. Great.
My apology, I've been out of the state, so. Sit down there, we can.
I have a copy. I can.
All right, great. Thank you, Ms. Garcia.
So
Mr.
this
Hafel.
report, quite timely, in light of what we're doing. And it's basically a report about the challenges of healthcare in a correctional environment. And I'll just hit the highlights of the report for you, and I guess I'll go to
Please.
Director's question. So the Pew Report demonstrates, if you have a copy, it's on page 5, that Oregon's healthcare costs increased 245% between 2001 and 2008. That information is not correct, and that is absolutely on us. Over time, organizations change how they're structured and what reports where, and the way things are budgeted. And so we believe that there's no way we were doing healthcare for $769 per inmate per year in 2001. We believe it does not include costs for mental health care. We're not sure that we think it includes pharmacy, but we're not sure. So our budget folks went through this thing with a fine-tooth comb back into line item cost centers to get actual numbers. And what it really looks like is 21.6%. So they reconstructed or recalculated this, doing it the way Pew did it, with the updated data. And it ends up looking like about 21. It goes from 48 million, where they show, it's back in the report somewhere, I think it's 19 million. It's actually 48 when you add the inflationary factor they added, which was 36%. The original number was, I believe, 45 or 35 million. That is what should have been reflected instead of the 14. With the 36.1% they added to adjust to $08, it would be 48 million. We actually spent 74 million in fiscal year 2008, not 84. That was actually fiscal year 2009 information. And the state looks at fiscal years depending on what part of the state government you're in, what constitutes 08 or 09 fiscal year. For us, 08 is July 1 of 2007 through June 30th of 2008. What actually got reported was July of 2008 through June of 2009.
Bill, you know, we went through the accuracy of reporting and various data analysis, and it became a very hot, contentious topic during our work on 3194. I think it would be helpful if what you're explaining to us today, the disparities and in it, that you actually kind of give us that in a written form, because I'm certain that that will come up again as we begin digging into healthcare costs. And that was, as you know, we could not even talk about certain issues without the issue of of how accurate is the data as it's in comparison with nationally. And in fact, so much so that that is part of the legislation that was passed. So I would, ask that you actually give us
Okay.
where the variables are and some explanation as to why.
And we can certainly do that, Senator. In fact, we're preparing that information now so that we can share it with Pew and actually even ask for an amended.
That would be good.
Amended report. They'll want it to be accurate as well. So we appreciate that relationship, and we'll reach out to them and share that information with you. The errors aside, which as Mr. Hafel said, we own because we believe we fed the data to them. Setting that aside, this really does come at a great time because it does talk about a lot of the ideas that are happening across the country in terms of mitigating the growth of healthcare inside corrections. So if, Mr. Hafel, if you want to turn our attention to some of those ideas.
Just one last piece of that, just full disclosure, the 2001 data they got at some point in the mid-2000s, so we couldn't even recreate what it is they got or who they got it from, so. Okay, so.
We'll do the best we can.
We will.
With what we have.
So the overview of this is, obviously increasing numbers increase your costs, but that doesn't explain all of it. And what they found is higher per inmate expenses and an expanding slice of corrections budgets devoted to healthcare, which I think everybody recognizes. The things that are drivers, they find, aging inmate populations, prevalence of infectious and chronic disease, mental illness, substance abuse among inmates, and many of whom entered prison with those problems without treatment or medical care. And then challenges in the prison system inherent in delivering health care in a prison environment, as well as distance from hospitals and other services. They note that effectively treating inmates' physical and mental ailments, including substance abuse, improves their well-being and can reduce the likelihood they'll commit new crimes or violate probation once released. They interviewed correctional health care experts across the country to identify innovative strategies to reduce costs. A review of their report shows some promising approaches, use of telehealth technology, which we're working on right now, actually in conjunction with Oregon Health Sciences University, who are creating an entire division around telehealth, telemedicine. We've just recently, in the last biennium, upgraded equipment and bought some medical carts for our bigger facilities so that we can begin to utilize that. And I think training for that occurs this month to be able to begin using that and rolling it out. And so we'll see where that takes us in the future. But each facility is equipped with some new televideo equipment. We're hoping to be able to connect particularly in the rural areas where distance is a problem. Also, management of health services contract. Yes, ma'am.
When you talk about distance as a problem, can you just share with this group our recruiting difficulties in rural Oregon? I know we have
Yes.
pretty substantial vacancies
Specifically right now, a real live case example is between Two Rivers in Hermiston and Eastern Oregon Correctional Institution in Pendleton, we have 3 full-time physicians and 3 full-time nurse practitioner positions. Right now, we have 1 of each filled. We've done everything we can. We're actually sending, I don't know if we've sent them, but sending letters out to every nurse practitioner and physician in the state and in Southwest or Southern Washington. We've hired a headhunter to find physicians for us. They've been on board for, I think, 3 months now. They have found us some candidates in the Valley. We have yet to find anybody over there. So actually, we have an infectious disease doc, Dr. Dusnip, and our medical director, Dr. Shelton, and Dr. Perini, who's the chief medical officer at OSCI, have been traveling 1 week a month to Two Rivers to see patients to support the nurse practitioner that's there. We did find a contract doc that's willing to work some hours at Eastern Oregon Correctional Institution, and that right now is how we're getting by. But we have 4 positions vacant at those 2 facilities right now. And clearly, having those people go out is not a long-term solution.
Is that for general medicine practitioners?
Yes, yep.
May I ask?
Please.
Mr. Hayfel, you said the equipment for telemedicine is in place at all the facilities now?
Televideo equipment is in place at all facilities. Telemedicine equipment is in locations, I think we only ended up putting it into places that have infirmaries.
Okay, just.
Yeah.
Okay, but it's there now?
Yes.
It's usable and training?
And training's occurring
is
over the
occurring
next,
now.
like over the next month.
Okay, well, that's real positive.
Thank you. So the management of health service contractors, the specific case example in the report is California, who was sending inmates out the hospital for hospital care and didn't really have a network. And so they were essentially paying what the hospitals billed. And I believe we've addressed that through the use of our discounted network through First Choice Health and the use of our third-party administrator. Medicaid financing, which, we are pursuing, we're headed down that path now of Medicaid reimbursement for inpatient hospital care. So I think we're right on track with that.
Welcome.
And medical or geriatric parole. So what I can tell you is currently, and I don't remember what 2011 or 12 were, but in 2008 we released 3 inmates, early parole release. In 2009 we released 3, and in 2010 we released nobody. So there is on page 25 of the report, it's a standardized framework for medical and geriatric parole. And it's a group of researchers led by 2 geriatric specialists, University of California at San Francisco, have made some proposals. And the group considers the medical eligibility criteria in most states is clinically flawed, because in part it requires physicians to predict limited life expectancy and functional decline. So such requirements exclude prisoners with severe but not near-death illnesses such as dementia who are incapable of causing harm. I will candidly tell you, I'm not sure dementia or Alzheimer's would keep someone from causing harm.
That's
And then participating in rehabilitation or experiencing punishment. The second, researchers criticize what they'd be to be overly onerous procedural hurdles in many states that prevent inmates with cognitive incapacities or illiteracy from being able to apply. They also argue the process may be too lengthy to evaluate and release a terminally ill inmate before death. Now, as we've testified before in legislative hearing, when you're going to release a terminally ill inmate, we're not going to save that much money. You need to know that, because we've already treated them and treatment failed. So that money's spent, and now basically what we would save is the cost of bed days. And potential other maybe hospitalization costs over time, but typically when they get to the point at which they're being considered for release, they're short-term.
Director Boxrust?
If I may go back, thank you, Madam Chair. If I may go back to the Medicaid piece, on page 20, there's an observation that most of the states terminate Medicaid in release coverage upon incarceration, and they're recommending, rather than terminating, suspending that. What are we doing?
And we are meeting with Oregon Health Authority, and that is the path we're headed towards.
Great, thank you. That's great.
And according to them, it just takes a rule change, because it's in their rule that they terminate, and they're perfectly willing to suspend.
Great, thank you.
And I think it will help dramatically, in fact, if you can speak a little bit about what the world looks like today, because right now, when we terminate, we're not allowed to even, the adult in custody isn't allowed to submit that paperwork until they are no longer incarcerated. So it literally means we can't prepare them for that application before they leave.
And
then the
it kind of
delay.
still looks that way. So we had originally thought early on that we would just basically do an application for everybody and submit them. But in working with OHA, the fact that they're incarcerated precludes them from being eligible. So where we're headed now is we will chase those who go into hospital and get applications submitted for them. We will still fill out applications for the offenders, but likely not submit them unless they're either hospitalized or at the point of release. And what OHA has told us is we submit the application electronically, they can actually real-time determine eligibility. So as they walk out the door, we hit the button and send it, they determine they're eligible, and they should walk out the door with coverage.
So, Mr. Hateful, does that mean even those individuals that because I was talking about that future state where an adult in custody comes in, we suspend rather than terminate, and then that reentry is more smooth. So you're saying even with those who are in our custody today, we have terminated, we're putting a process in place that will automate that and make it far more effective?
Yes. So, well, and
Go ahead.
so at this point, in Oregon, it was still only income in terms of, but there was no single coverage without dependents, and that's what's changing in January, along with no limitation on pre-existing conditions. So we're frankly pretty excited about what this looks like going forward.
So, and my understanding is that we've actually begun to suspend rather than terminate at this point in time.
Did not know
from my
that.
conversation this last week.
Great, thank you.
That's good. And then the next step would be, once they leave the facility, to actually have some sort of a warm handoff to the coordinated care organizations, rather than leave it to the individual to, navigate the system, and so that would be an important step going forward.
So is it safe to say that the work of the handoff with the work that we're doing on reentry with an OIA will be compatible, hopefully, because we're all sitting here saying that 90-day in preparation of the individual leaving the institution, that once they leave the institution, that hopefully healthcare and all that is in play, that we don't have to.
Right. That is certainly
That's the plan.
goal. That's the plan. And it's important.
And the CCOs around the state are being educated and on board?
Well, my conversation 2 weeks ago was with the medical director for Health Share of Oregon, David Labby,
Okay.
Dr. Labby. And so that's, Dr. Labby tells me that his colleagues around the state and the coordinated care organizations are very much supportive of this and getting information about individuals released into their region as early as possible, and then having some sort of a navigator, potentially a peer navigator, connect with these individuals and make sure that that their immediate health needs get addressed.
So going backwards, looking at some of the other DOC, electronic records would be actually helpful if you're talking about from there to the
Absolutely.
CCOs.
Extremely helpful.
As I think in terms of movement and the accessibility of information.
Right. That would be extremely helpful. One piece that is available is the claims data through the third-party administrator, which would be then accessible electronically by the coordinated care organizations, which would help a lot.
Is that also true of OIA?
Sure, it would be true of OYA, and no reason why not. Oh, I don't know, actually, and now that I think about it.
I actually don't have the answer to that. I'll look into that and let you know.
Because not some of your customers would also need, when they're released, to be in the Oregon Healthcare.
What we are doing currently is that we are making sure that the youth who leave our care and custody are signed up with the Oregon Health Plan. There may be those who fall through the cracks, but that is a practice currently. And, Dr. Adams might be able to clarify.
We would like to, feel free to. Excuse me. Thank you, Madam Chair. We would like to
Welcome. Can you, for the
participate
record, tell us who you are, Dr. Adams?
For the record, my name is Dr. Marcia Adams. I'm the Medical Director for the Oregon Youth Authority. I would like to participate on what you just outlined, because if our youth leave OIA, they also their Medicaid is also suspended when they come in. Well, totally take it away. And so if it could be suspended and if they could get it as soon as they're leaving, that would be helpful. and to be able to participate in the CCO, so there's no gap in coverage. So we would like to also participate in something like that.
Is there any way to, under the Oregon Health Authority rulemaking, that, because what we're trying to do on the correctional side is beginning the planning for transitional release 90 days ahead. And so when we start talking about sharing information and signing up individuals and what have you, to actually begin looking at those benchmarks so that by the time that, whether it's OYA or DOC, that the individual, when they're out that gate, that all the paperwork and everything has been done in the community part of the system.
So Senator Frye, I'm hearing you correctly. I'm hearing two recommendations that we will want to capture. One, electronic health records as a recommendation, and also that we ensure that we're actually measuring the number of individuals who are leaving signed up for the plan, either regardless of if they're at DOC or OYA. Is that correct? That we set up a state measurement to measure that?
Because what you want is the consistency, from the, from leaving the institution. I was particularly thinking, and like I said, I was back in DC with the Women in Government, and one of our speakers was talking about, HIV and those meds, and what happens in some places where the individual leaving the institution are no longer taking their meds.
Right.
And so, and that's extremely serious coming back into a community. So, it's some of those issues to assure that we're having the consistency or the continuity when the person is leaving the institution, the various institutions, whether it is the adult system or the juvenile system.
So Senator Winters, what comes to mind as we talk about that is personal health information and what restrictions there are about giving personal health information to a coordinated care organization before an individual is actually enrolled in that coordinated care organization as a covered entity. And that is a problem, is it not?
Yes.
So that limits the ability to get information out to coordinated care organizations in advance of the release. And once the release occurs,
Yeah, even if the release is signed?
pardon me?
Even if, once the release is signed, though, however.
Once the release is signed, well, once the individual actually is released. Right.
Can't you have a pending file? I'm just trying to think of ways of removing that.
So that's really, no, this is a really important topic. And so I don't know if there's anything that could be done legislatively to address this or not. But certainly anything we can do to make sure we give advance notice, advanced information about people who are being released into the community and to the coordinated care organization they're going to be assigned to. So the sooner that happens in the process, the better.
Mr. Havel, can you talk a little bit about what we did legislatively or by rule? I'm not remembering, for those with extremely high mental health needs. Weren't we able to?
I think that was Senate Bill 913, and we actually have people working actually on both sides out, both medically fragile and mentally fragile, to ensure that they have wraparound services upon release, but that's a limited population. And the one side, the mental health side, is legislatively or legally driven. The other side is just because we know it's the right thing to do.
So is it your sense that legislatively we could pursue something that would kind of draw back our ability to give advance notice to the community and to the federal authorities to ensure a more seamless transition?
So I don't think the issue, I don't know that it's a legislative issue.
Okay.
Maybe it's around finding services.
Or maybe it's just really collaborative that can be done with the Oregon Health Authority and figuring that pathway.
So am I hearing that as a formal recommendation as well?
Yeah, because, part of this is bringing the two entities together to figure and removing barriers that
Right.
sometimes the one entity doesn't even know exist and can find through rulemaking that they can solve the problem.
Great.
So
So we can include that as a recommendation to review for possibilities.
Okay.
Thank you.
And one thing that's not actually in the Pew report, but was in an article I just read recently, kind of around the whole Medicaid piece, and this is maybe a bigger picture topic than just DOC. When we talk about reducing costs for DOC is talked about the availability of Medicaid to cover mental health treatment for people and getting to them before they get into the criminal justice system. That's a way bigger topic than me, but I thought I'd pass it on because I just read that article in the last couple of weeks.
But it's a maybe a bigger topic but it's a topic that our communities and our jail systems, I know, would love to have those conversations because of the not only financial impact, but the misuse of jail space and what have you. So I do.
I'm glad you mentioned that, Mr. Hayfield. We've just now begun to see national articles talking about how those of us in Medicaid expansion states are likely to benefit from a public safety perspective on the front end, prior to committing a crime, and on the back end. So we'll be looking at those outcomes as well. Okay. Director Poxrush, did you want to add something?
Just that, also, thank you, Dr. Adams. We also face the same phenomenon in the juvenile system. We have a high percentage of our youth who are diagnosed with mental health conditions, and in some cases, in few cases, even the judges are apologetic that they're sending these kids to us because there's no other places for them to go. And frankly, our environment is one of the worst to be able to deal with mental health situations. So we're not making things any better. So I appreciate that point.
The question I had is, you touched on medical paroles. If we have an inmate, I guess hypothetically speaking, that's a quadriplegic, what would stand in our way of releasing that inmate? What is...
Sentencing.
Pardon me?
Sentencing.
Sentencing guidelines purely.
At this particular point in time, and I know the hypothetical case of which you speak, not eligible.
And so one of the things that we've talked about, and we've actually talked about this hypothetical case, Mr. Miller, in front of legislative committees, this particular case costs us approximately $50,000 every month. He came to us not a quadriplegic, but was injured while he was inside our facility. And the law, while I do not have it memorized, has some pretty strict parameters around what cases we can and cannot let out. Sex offenders are a category that we cannot, and it really limits who we can release. So when you look at our aging population, so that population that is the most costly, that has the most chronic disease, many of those individuals are sex offenders, because who do we send to prison the longest? Those that kill and those that commit sex offenses. And so while I think it's definitely a path we should pursue, and I hope this committee makes a recommendation that we at least consider expanding who we can release under that existing law, it does become complicated given the scenarios.
And that would be the population we have the most difficulty finding releases for
Right.
on release.
How are other states, I mean, because we're not unique, that the issue of who's actually in our system longer, is with other states as well, and other states are also grappling with the same issue that we are. And I just, someone sent me, emailed me the other day, some information of what other states may be doing, but I think it's worth looking at how other states are addressing this particular issue, because it's a thorny issue, it's politically charged, and yet we know that that's where they're older, sicker, and I said, well, can we put an ankle bracelet on them and chain them to the bed? And somebody said, well, no, Jackie, you can't do that. But somehow we've got to come up with some answers to this particular population.
So the Pew report actually speaks to what other states are doing, so I'll just draw your attention to page 22 of the report if you do have it. 15 states in the District of Columbia had geriatric release provisions in place. 39 states had medical parole statutes for inmates with terminal or debilitating conditions, but in practice, like Oregon, states have released relatively few people, and I'm sure it's for the very reasons we just discussed.
So on that note about other states, one piece I forgot to touch on was, there was a question around what are other states doing, and we had talked about that we meet somewhat frequently with Washington and California to kind of compare and talk about, brainstorm about what's going on. We're actually, that meeting takes place this Thursday, so we try to do it quarterly. Sometimes things get in the way of that, but we are meeting this Thursday, so.
Madam Chair,
Representative?
on that point, and looking at the costs, their costs are higher than ours. Is there any reach out to some of these states that are like on the bottom third of this cost that we're brainstorming with? Washington and California cost per inmate's higher than Oregon's, according to that chart.
Mr. Havel, at this point, have we engaged other states?
I've had conversations with peers in other states. To some extent, part of it is lower cost of living, where some of those are. I'm not sure about, clearly we had questions with our data. If you tell me that Louisiana's cost per inmate per year is relatively low, I'm not surprised at that. You tell me Illinois is the lowest in the country, I am surprised at that.
So maybe what we can do, Representative, is be strategic and look at the bottom end of the list, the low end of the list, and do some reach out to
We will look.
3, 4, 5 states and
Yep.
at least pose the question.
Yeah.
Good.
It's just an observation based on like you're right, the data we've been given, how accurate is it? But it's some data there on page 5.
Thank you. Okay. Anything else you'd like to draw our attention to with this report?
No, I don't believe so.
All right. Any other questions? Director?
Bill, so it sounds like we're actually hitting all of those points recommended in the report. You're already working on all of them.
Yes.
So, again, congratulations.
We're pretty happy to see that. I mean,
Great. So, thank you. Great.
Although I was hoping for that silver bullet, right? I was hoping for that
Yeah.
nugget that we didn't think of. Thank
I was
you,
hoping
Director.
for that as well, Director. But at the same time, kind of hoping that we hadn't missed something big.
Right. Agreed.
So-
Agreed. Well, we'll reach out to a few other states and see if there's anything else out there innovative that we haven't thought of.
Speaking of the geriatric population, and where we've got infirmaries and what have you, are they tiered? Do we have steps and what have you? Because I know we only have the one vacant facility that's all on one floor. And you talked about if you've got a serious problem of having to transport someone back and forth and what have you. And of course, it's no secret that this senator thinks that we ought to put that one facility that's all on one floor to use with geriatrics. But
Mr. April?
And in all good conscience, my response to that would be yikes. At some level, if we're talking about Deer Ridge, the availability,
no,
OSPM.
OSPM,
my late.
And
my-
we've done that
my-
analysis.
yes.
And shared the cost of that retrofit and it's quite costly because it is an old building, and then plumbing it, if you will, for medical services was quite costly. But from a medical perspective, Mr. Hathel, would it,
So the medical area would have to be expanded because it is, as you probably recall, is very small. And if we're going to put a sick population in there, that needs to be expanded. And then there's the staffing costs and the basically reconstruction costs. Is it's going to have to be made ADA compliant, which it's not now. It is all on one level. And I do believe, I think our facilities unit did the analysis
we
on
did, and
what
we
that would
presented it
cost.
to the Public Safety Subcommittee. Would you like us to bring that analysis back for next time? And I'm also hearing you request that we research what other states are doing in terms of geriatric facilities.
Because and the trends are saying our population is getting older and sicker. So, we are going to have to address the issue of what do we do with this geriatric population. I mean, we're not talking about, we're used to, your age was not talking 70 and 80 and 65 and plus. So, I mean, it does pose a problem in how we address that problem in a costly way. You've got, I don't think I ever thought we'd be talking about having to put dialysis machines in prison. I don't think I ever thought about that you're talking about pharmaceutical costs of $40,000 a month. We didn't think that we'd ever be, we would be dealing with some other issues that we're dealing inside of the prison population. So I think it's something that we are going to have to really seriously assess and looking to the future, not just for currently right now, but looking to the future of how we actually address it. Now, unless you tell me that somehow it's going to turn around and the population is going to revert back to being younger.
Those are not the crime trends that we see, Senator.
With all due
Thank you.
respect, ma'am, I am not saying that.
Okay. Thank you. Any other questions or comments from the work group? Once again, thank you very much.
Thank you.
And with that, our next presenter is Jeff Van Valkenburg, our General Counsel from the Department of Justice. He's going to talk about correctional health care and the legal framework. We have been waiting with bated breath for your presentation.
Thank you.
Although I am disappointed Ms. Bodkin isn't here because I believe this was her request, so we may need to follow up with her. You'll brief her? Thanks, Representative. Mr. Van Valkenburg.
Chair Peters, members of the work group. For the record, my name is Jeff Van Valkenburg. I'm with the Department of Justice. I've been the General Counsel Contact Attorney for the Oregon Department of Corrections since 1989, so I've been doing this for some years. Thank you. Let me preface my remarks that I'm here in my individual capacity as counsel for contact counsel for the Department of Corrections. I'm not here for the Attorney General for the Department of Justice, but I think that what I have to say might be useful for you. I want to thank Heidi Moab and Director Peters for inviting me here to give you a little legal framework for the constitutional right that prison inmates have for medical care. We know that inmates in all states, including Oregon, have a statutory right. But I think it's more useful that we focus on the constitutional right because that's beyond the legislature's power to affect. So I apologize for the 3 slides on here. My eyesight is also getting more difficult as I age, but I tried to make these as large as I could. And if you need a bigger size, I'm happy to provide that at a later time. So I thought what we would do is focus on the nature and scope of state prison inmates' constitutional rights to medical care, mental health care, and dental care. It's all the same. We talk about the sources of those rights, a little bit of the history of what the federal courts have done with that, what the state courts have done. I think it would be useful for us to talk a little bit about what's happening in California because that's on the extreme, and I'm sure that many of you are aware of the federal court litigation that's been ongoing in California for these many years, and it's gone all the way up to the U.S. Supreme Court in very significant, unprecedented federal court intervention in a state's operation of its prisons with the delivery and administration of health care. So I thought we'd talk a little bit about that. I'm happy to answer some questions after. So if we might start, state prison inmates do have a constitutional right under both the federal Constitution, the U.S. Constitution, and the Oregon Constitution to medical care. The source of the right is the cruel and unusual punishment clauses of both constitutions. In the U.S. Constitution, the source of that right is the Eighth Amendment. In the Oregon Constitution, it's Article 1, Section 16. The text of the Eighth Amendment is excessive bail shall not be required. That doesn't apply here. Nor excessive fines imposed, nor cruel and unusual punishments inflicted. The Oregon constitutional provision is very similar. Cruel and unusual punishments shall not be inflicted. Does the text say anything to you about medical care? Maybe, but for many years, those provisions were not interpreted to provide substantive protections for state prison inmates. For many years, the federal courts, we refer to this as the hands-off doctrine. For most of the nation's history, the federal courts did not intervene, did not breathe life into the Eighth Amendment to provide a substantive level of protection for state prison inmates. That began to change early in the 1970s. And some of you have been in this field and been around and followed this for a while, know that's when the federal courts started to begin to expand the protections for state prison inmates under the cruel and unusual punishment clause under the Eighth Amendment. So the way that the federal courts have articulated the Eighth Amendment is to say this. In a series of decisions, they've decided that the states must provide its prison inmates with the minimal civilized measure of life's necessities. That's the framework. And included in that framework, the federal courts have said, is the right to medical care. The other things are food, clothing, shelter, sanitation, and personal safety. But Medicare is one of those core human needs that the courts have recognized that the Eighth Amendment protects. We've had lots of litigation in Oregon on these issues over the years, and I've put down some of the fundamental cases there for your use. The main case out of the federal courts is a case called Estelle versus Gamble. It's a 1976 case. And what the court said was that the deliberate indifference to the serious medical needs of prisoners constitutes what? The unnecessary and wanton infliction of pain, and that is what's prescribed or prohibited by the Eighth Amendment. Excuse me.
Jeff, a question. How serious defined?
Serious is defined in a number of ways, Director, but and I have some slides on that.
Okay, great. I can't wait.
There's two concepts in the Eighth Amendment, and as I provided my materials, Oregon's courts have also adopted the same Estelle standard for the interpretation and application of Article 1, Section 16 under the Oregon Constitution. So we're dealing with the same standard. That often is not the case in Oregon. You may be aware that Oregon has interpreted its state constitutional provisions, its Bill of Rights, in a substantive way that sometimes is more protective than the federal courts have interpreted the federal Bill of Rights. But as to the Eighth Amendment medical care protection, it's synonymous. It's the same. So one thing that I wanted you to understand is when the federal courts have interpreted the Eighth Amendment, it's not static. It has evolved and it has changed over time. And the concept that the federal court has used to articulate that is the concept of the evolving standards of decency that mark the progress of a maturing society. So there is this changing societal norm, and as our society evolves, the federal courts take that into account when they look at what the base obligation is of the states to provide medical care and to provide these other basic human needs under the Eighth Amendment. So the Estelle versus Gamble standard, the Eighth Amendment standard, has two portions, two tests. The first is deliberate indifference. The second portion is to a serious medical need. So the right to medical care is not for any sort of need, it's for a serious medical need. And deliberate indifference by the state actors includes a mental intention. So this is not the same as malpractice, as negligence, as failure to follow a standard of care. It requires more than that. It requires that a prison official know that a prisoner faces a substantial risk of serious harm and disregards that risk by failing to take reasonable measures to abate it. In the doctor's area, this means that if they choose their medical treatment in the conscious disregard of an excessive risk to the plaintiff's health, that is deemed to be deliberate indifference. It's an intentional indifference. Director, what is a serious medical need? So the courts really have adopted various formulas for describing this. All formulations of the test of what is a serious medical need refer to what is the consequence of the failure to treat as evidence of the seriousness of the condition. The federal courts have used these indicia. The existence of an injury that is reasonable, that a reasonable doctor would find important and worthy of comment or treatment. The presence of a medical condition that significantly affects an individual's daily activities, or the existence of chronic or substantial pain. Oregon's Supreme Court has defined it in this way. If left untreated, it would have a significant adverse effect on an inmate's daily activities, resulting in substantial and recurring pain or discomfort, or would create a substantial risk of permanent disability or death. So those are the standards that apply for defining what is a serious medical need that triggers the constitutional protection for treatment. So I already mentioned that Article 1, Section 16 of the Oregon Constitution, Oregon's Cruel and Unusual Punishment Clause, has been interpreted by the Oregon Supreme Court to be synonymous with the same legal standard, that Estelle standard, under the Eighth Amendment. So we'll talk about them together. So the Eighth Amendment deliberate indifference standard has been applied by the federal and state courts to do something more than just making a blanket decision. The courts have actually held in a series of decisions that the Eighth Amendment requires that prison officials make individualized judgments regarding the appropriateness of diagnostic tests, medical care, and treatment for inmates on a case-by-case basis based on the inmate's individual circumstances. Why is that important? It's important because it means that in practice, prison officials may not lawfully, may not constitutionally make a blanket decision to deny inmates particular medical diagnostic tests, treatments, or procedures based solely on budgetary reasons or other arbitrary reasons. And we have a case where we litigated this in Oregon in federal district court. It's the Delker case. It's a case that involved hernias. Oh. Now, you remember that, Senator Winter?
I do.
Yeah. This is the case, I can tell you since I was around when we litigated this case that I wasn't completely pleased with the federal district court's characterization of what the Department of Corrections was doing. But what it did decide was that denying surgery for simple hernias for all indigent inmates in order to minimize the cost, so based on budgetary concerns, was held to violate the inmates' rights under the Eighth Amendment. And what prison officials can do is to establish general guidelines for treatment of conditions including non-incarcerated hernias, but the ultimate treatment decision must be made on a case-by-case basis. That's what the federal courts have held routinely. So we all know that if a constitutional right is violated by the state or by state actors, there are judicial forums and there are judicial remedies that inmates can apply for to seek relief, to seek change. So typically what we see in the claims by inmates of constitutionally inadequate medical care, we see in federal court. We typically see it as a federal civil rights action. We see it under the federal statute, 42 U.S.C. Section 1983. That kind of civil rights action can be brought both in federal court and in state court, but typically it's brought in federal court. What's significant about these sorts of actions is you can get not only money damages for the violation of the right, if it's proved, but you can get injunctive relief, or both, plus attorney's fees. So there's great exposure for prison officials and local officials running the healthcare in the jails when we see these sorts of federal civil rights actions. In Oregon, we also have a state cause of action that can be filed in state court. It's called a state habeas corpus petition or action. What's unique about it and how it differs from the federal civil rights action is you can get injunctive relief only. Injunctive relief is when the court says, do this differently, either refrain from doing something or do something you're not doing. There are no damages and there are no attorney's fees. But interestingly, in state court, under our state statutes for state habeas, inmates get court-appointed counsel. And so we do see a lot of litigation. I don't know what you see in the county as far as state habeas, but we see a lot of it on the state level. But primarily, it's the federal civil rights actions. I told you that I was going to primarily focus on the constitutional right and the violation and the remedies, but we all know that the Department of Corrections physicians and licensed healthcare professionals are subject to negligence actions as well, just like any licensed professional in any practice setting. So we do see those. I told you that I wanted to speak a little bit about the California case law. How many are familiar with the Plata and the Coleman cases? Are you all familiar? Many of you are not.
Are you glad I raised my hand?
I am
Counsel?
glad that you raised your hand, Director. I've tried to keep you advised of that. I'm sure you do independently as well. These are long-standing class actions filed in federal court. The Plata case in 2001, the Coleman, Plata case was on medical care. The Coleman case was on mental health care in the California system. These are separate class actions. Although they were decided separately, they resulted in some similar outcomes. The district court, federal district court, in each case determined that the lack of adequate physical or mental care violated the prisoner's Eighth Amendment rights, leading to years of court orders designed to remedy the violations. I go to conferences and have for many years across the states, and I confer with my counterparts, and I want you to know how somewhat unique Oregon is to have so few court injunctions, so few court orders. What's Oregon's system? About 14,000 inmates?
14,600.
Okay. California's is 155,000, somewhere thereabouts. I'm very thankful to be a native Oregonian, represent an Oregon agency, represent the Oregon Department of Corrections for these many years, because we simply have not had the systemic kind of problems in my history with the department that many states have, and California is just an egregious case. So, in both of these cases, these were originally brought against Governor Brown. When Governor Schwarzenegger came into office, he declared a state of emergency due to prison overcrowding, and the inmate plaintiffs in these class actions argue that the only means of remedying these very significant, systemic, long-term deprivations of their right to medical care. I don't. If you've read any of the reports from California, the estimation from the special masters in the federal district court was that at least one person a day was dying in the California prison system unnecessarily because of the lack of access to adequate medical care and mental health care. And obviously, I think we all agree that one is too many. So that is why this is the outside edge of an egregious situation that I think we need to pay attention to. There's a unique federal statute that maybe some of you are aware of called the Prison Litigation Reform Act. It has a remedial provision that allows a three-judge panel to actually order a release of prisoners. That was done in this case. The design capacity for the California system is about 80,000 inmates. And we're talking almost double that is the actual population. So the federal court agreed with the plaintiff inmates and did order a very significant release that went up all the way to the U.S. Supreme Court. And in 2011, the Supreme Court held that the remedy that was ordered by that federal district court three-judge panel to release wholesale inmates from that prison system was valid, was within the power of the federal court. Think of the intervention that represents for the federal government to come in and operate a state system. We had not only monitors appointed in that system who were special masters who would find facts and who would look at whether or not the California prison officials were actually doing what they said they would do when they consented to injunctions over time. We also had something that, in my experience, is unprecedented in the area of federal court intervention, and that was that the federal court appointed a receiver. Healthcare delivery and administration in California is currently under a receiver. I've never seen that as a remedy in any case in the country, in my knowledge. I think that reflects the type of such large-scale, systemic, long-standing deprivations that this is going all the way to the Supreme Court. The Supreme Court says that's within the power of the federal government to reach into the state and actually control and make sure that those prisoners' rights are protected. So that's sort of the outside guideline of what we need to be concerned about, and I think should help inform your judgment about what Oregon is doing. I frankly, from a personal perspective, would not like to see us get to that point. I'm sure that you folks feel the same.
Have there been any other states that this has occurred, that federally they've come in and have a, besides California?
Well, Senator Winters...
Because once when you think of some of the issues that were raised in California, that not overpopulation, but some of the medical and some of those, it comes to mind that maybe there were other states across this country, but California's been highlighted, and that suit came out of California, so I'm curious.
Senator Winters, members of the work group, there's an old case. Most of the class action in the medical cases started in Texas back in the 70s. The first case was a case called Ruiz. And it was a class action. It lasted for many years. I'm sure there were court masters appointed that, at least I believe there to be. And then Estelle itself also was out of Texas. I know that all over the country, these sorts of issues are litigated, and there will be other states in which masters have been appointed. But I have never, in my experience, seen a receiver appointed to run a state's prison health care system. I think that's unprecedented. I'm not aware of another case.
Wow.
So to sum up, official custody is what establishes the constitutional obligation under the cruel and unusual punishment clauses of the U.S. and Oregon constitutions that require that Oregon provide prison inmates with adequate medical care for their serious medical needs. The essence of the constitutional obligation is for the government to avoid the needless infliction or the prolongation of pain and suffering of persons the government confines for the conviction of crimes. The scope of the duty, of the constitutional duty, extends to providing inmates with adequate care not only for their medical needs, but for their mental health needs and their dental needs. Prison officials have a constitutional duty to make individualized judgments regarding the appropriateness of diagnostic tests, medical care and treatment for inmates based on the inmate's individual circumstances. As we've discussed, the failure to provide adequate care and treatment for serious medical, mental, and dental needs violates inmates' constitutional rights, exposes states and state prison officials to suit in federal and in state court, and to liability for damages, for injunctive relief, and other significant judicial remedies. In egregious cases of systemic and long-standing violation of inmates' constitutional rights to adequate mental health care, the federal courts have the power to intervene, to impose wide-ranging injunctive orders on the states, to install special masters and receivers to take over the delivery of medical and mental health care to the state prison inmates and the administration of the state's prison health care system, and ultimately to order the wholesale release of inmates from state prisons. That's the lesson from the California litigation. So that's all I have, but I'm happy to answer some questions if you have some.
Thank you, Counsel. Questions?
Just a quick one. What has been the financial cost to California?
Senator Winters, members of the work group, actually, I know California's counsel, my counterpart, and I tried to reach him on Friday, and he was getting on a plane, and he's going to come back with some information for me, so I think I can provide that to you. But But if the litigation started in 2000 and 2001, you can just imagine. I think, if I'm not mistaken, the latest status in these cases is that Governor Brown, again Governor Brown, has sought some sort of relief from the release order, and the federal court has said no, emphatically. So again, the release order was to release about 40,000 inmates from that system within 2 years. That order was 2011. I don't know what the status of that is, but I'm going to find out from their counsel, and I'll report back to you.
Thank you. And I think also not just the cost of the actual litigation over that decade-long period, but what it has done to the cost of health care inside the prison walls.
But also, because I knew when this first came up, there was the concerns in communities, and what that cost with those releases in the communities, and the communities were not prepared and ready for the 30,000. So it was more than just the prison cost and the healthcare cost, but it was also the community cost. So it's interesting.
Thank you, Senator. Doctor?
Were they measuring recidivism rates, the ones who came back that were released?
I really have no idea about that on the clinical side and on the correction side, whether they were measuring that.
That would be interesting.
Yeah, it would be.
Why don't I ask their counsel, see if they have any information on that, and report back to you.
Thank you.
And if not, I'm sure our research office would be able to find something so we can work together.
Very good.
Thank you. Any other questions? Director.
Thank you for the presentation, very enlightening. I'm just curious, in light of the previous presentation, the Pew report, and this presentation, if the variation in healthcare costs across the states could have something to do with how we interpret serious need for medical care. I don't expect you to answer that question, but it's just a question for me.
Let me say this. It matters that we're in the Ninth Circuit. For any of you who have been in this area and worked in this area over time, you know that the Ninth Circuit is a little bit more protective than any other circuit in the country of prisoners' rights. I'm not meaning to say that any other circuit would not have found this, or the district court would have found the same egregious violations of rights as they did find in California. But I think it does matter that Oregon is in the Ninth Circuit. I see it not only in the medical care area, but in other areas. Many years ago, when I went to a NAG conference, and I was looking, or they had a speaker from one of the law schools. It was a constitutional law professor, and he was talking to us about the Supreme Court decisions that term. One of his 3 themes was the Ninth Circuit gets reversed, and that's because when cases go up to the U.S. Supreme Court from the Ninth Circuit, there's a much higher probability that they're a little further out there on the edge of what the court has felt comfortable with. But look here, what happened in this case? In this case, the U.S. Supreme Court upheld the power of the Ninth Circuit and those federal district courts in that 3-judge panel. I think that speaks volumes about what all the federal courts feel about the importance of protecting the inmates' rights to medical care. I think it's an emerging area that will continue to be a challenge for the states.
Madam Chair, as I think this through, there appears to be a conundrum here. So I have a couple of questions. The first one is that the decision of seriousness is, as I understand your testimony, is one that has to be taken on an individual basis, one, i.e. each case you can't set a policy that says, here are all the criteria for seriousness. Am I right about that?
Within some respect, obviously, there are certain types of medical conditions which don't rise a level of any significant harm if left untreated. So those categorically can be excluded from the right. But for things where individuals in their individual capacity can result in the significant impairment of their daily life activities, or if left untreated can substantial physical harm over time, then yes.
And they
Yeah.
also said pain, and most of us know that's a difficult thing to
Yes.
measure. To what extent one can measure that by labs, et cetera, is actually fairly small, and let's just relate it to a discrete disease that's identifiable.
Yes.
And so having a patient with pain that is intractable, and the patient feels that their life is really not of the quality it should be based on that, is something that becomes subjective. And my question is, when a case like that occurs, who makes the decision? Is that prison officials, or is it the individual physician staff? What's the requirement for that decision?
Let me say this. First of all, I'm not presently defending the department in these cases, so I'm not entirely familiar with what's going on in the federal district court in Oregon right now on these sorts of issues. But yes, as a rule, if a Department of Corrections physician makes a diagnosis and has a plan for treatment, and that's within the range of professional medical judgment, there's a measure of protection. It would be more difficult for an inmate to make out a violation. What I'm aware of, just from experience, is that these issues of chronic and substantial pain are difficult issues to litigate. As you say, they're subjective in nature. I know that clinically there are ways that the department or any practitioner would try to objectify the findings and to help present the best medicine, the best clinical decision in the case. But you're right, those are significant challenges for practitioners when we have the self-report of pain and there's a lack of objective findings. So
And what's also behind my question is is that, as I understood you, and in reading this, the clinical caregiver also has individual exposure.
Well, that's true at a level, but in Oregon we also have a statute, as most states do, that indemnifies and gives protection to the employees of the state and other public bodies for their torts. And medical malpractice and constitutional torts would come within the scope of the Tort Claims Act and that protection. So it is the case that any state actor, including our employee physicians, are covered by those provisions, so they are not facing the loss of a house or car for a mistake. And as long as they're acting in good faith in the course and scope of their employment, and they're not acting willfully, intentionally, for the very purpose of harming the inmate, the statute provides that kind of protection. Most states have that.
That's right, but I'm also aware, having been for some years and attending in public institutions, that acts as a drag on how far you want to reach in declaring a person who has symptoms that cannot be verified by laboratory or some other objective measure. It tends to not want you to discharge. It tends to have you less aggressive, because there have been suits, and whether or not you're covered by the Attorney General sometimes is a decision of the Attorney General, because the fact of whether that it was negligence or not has to be discussed, and that is a devastating discussion to be in the midst of if you're a physician. And I've managed some that have been in the middle of that. So I suspect in some ways that is a drag on and I may not be using the word appropriately here, but it's a disinhibitor of being aggressive about some discharges. Now, whether that's statistically significant or not, I think it's something that we have to be aware of. What is the milieu for treating people, i.e. the clinicians, in our desire to discharge? Mm-hmm. I think that there is some hesitance to reach out there if you don't have all the evidence. Mm-hmm. maybe that's 10% of the population that happens to. Maybe it's 15%, but I would imagine it's a factor.
I think that's a question probably better addressed by Mr. Hafel or DOC's Chief Medical Officer, but I would say this. I've been around these many years. Not once have I seen the Attorney General's office not cover a DOC employee physician acting within the course and scope, but I've never seen one acting outside. I've never seen a doctor that the Attorney General has found acted for the very purpose of trying to cause harm. And so we get to make mistakes as public employees. Doctors make mistakes both in the private sector and the public sector, and the statute covers that. So I know that when my colleagues go over and give trainings, or when I give trainings to the Department of Corrections doctors, one of the things that we emphasize is this right to defense and indemnification under the Tort Claims Act, because we want to break down any concern so that there isn't an artificial impediment to their making sound clinical judgment. So I hear what you're saying.
Thank you.
Well, the variable of potential appeal lawsuits, because you have a population who has probably a better legal library than most. And
let me assure you that they often do.
Yes, and they have no hesitation.
That's right.
Of actually using that particular system. When you talked about the hernias, I think part of that decision, even in Wayne, is that, I think the population, I always say that they probably have a better communication network than AT&T. So if there is a decision out there, you bet your sweet bippy, no matter whether that is warranted or not, they know about it. And which there is.
My experience echoes yours.
And
Any other questions?
Madam Chair, I have one quick comment.
Sure.
To the topic of assessing the cost to California for these cases, I just want to echo what Senator Winter said. I think it's an excellent point at the local level. Those costs will not be determined for years to come. 2 days ago, I was at an accreditation hearing where agencies from across the country were going through their final phases of determining whether or not a national accreditation entity was going to continue to accredit them. And so I got to hear from chiefs around the country, and some from California were just describing the challenges as a result of this order and returning so many inmates in at once back to their local communities, and the challenges not only on a public safety side but on public health. And they're just coming to terms with them. So it is definitely a cost that it's impossible, I think, to really measure today. That's all.
Yeah.
Thank you.
Thank you. Thank you. Great point.
And I raised that issue of the continuation of medical care because if you look at the California, what's occurring there, and I immediately came to mind with HIV, and I suspect that they have a lot more challenges than what we have here in Oregon, and that's one that most people don't want to talk about anyway. That's one that you don't want to share with, and if that continuity and that's not there, I mean, the unintended consequences that occur in that community that they're going back to could be very devastating. So, but I would hope that somewhere, because there is the defining what's serious, and also the standard of care as it relates to communities, because that also has not been between what the community thinks that should be the standard of care and what's inside of our institutions are not compatible.
And so what I will do, Senator, is I will channel Mary Bodkin for a moment and pose the question that I think you're driving to, and one that she asked on the record at our last meeting. She is sorry she couldn't be here, I think for two reasons. One, that she couldn't be here, and two, she's still in bargaining. But the question that she posed is, why isn't our community standard of care equal to that of the health care plan here in Oregon?
You mean the Oregon Health Plan?
Yes.
Yeah. Let me say this. First of all, I want to be cautious in my remarks, because I know that there was some legislation that was considered at least last session that would have affected this area. And what is typically the job of my office? To defend the legislature's power to enact legislations. But let me So these are my private remarks as contact counsel for the department, not for the Department of Justice, not for the Attorney General. As I described the Delker case to you, it's very clear to me that the federal courts have required that states make these individualized judgments not based on budgetary reasons or other arbitrary reasons. We all know that the very foundation of the Oregon Health Plan is this rationalization of what money is available under the legislative judgment in any given biennium and a continuum of care and where we cut off. That is an arbitrary judgment. That doesn't mean that sometimes that some of the procedures that the clinicians and the committees that make up the health plan, and they draw that line, that some of those procedures would fall down in that area that categorically may not constitute, for constitutional purposes, a serious medical need. But I would be concerned about having to defend a rationalization of where we draw lines of what is a serious medical need based on an Oregon Health Plan type model. I think we would run into trouble. That fair?
Agreed. But I wanted to have that on the record, so thank you, counsel. I
Thank you.
appreciated that.
So for the purposes of this panel and reducing inmate health care costs, already said that we can't establish a policy that would prohibit any procedure or whatever, or treatment. Is there any recommendation that you would have?
Let me say this. I'm not a policymaker, and I'm just a lawyer who gives advice. What I would say is it's been useful for me because I don't get to see all the, and get all the briefings that the Department of Corrections has internally on these matters. And for me to see Mr. Hafel and Mr. Martino's information was enlightening to me. So, and to hear the Pew report. So, I certainly don't have any ready ideas for how to help inform your judgment on that. So, I wish I did, but I don't.
All right, thank you for at least asking the question, Mr. Miller. We appreciate your presentation and your counsel as always. Thank you so much.
Very welcome. Thank you.
Okay, the next agenda item, and we are on time, is to talk about the next meeting and next steps. So I'll review for the work group some of the agenda items I heard from all of you, and then also a couple that I'm going to recommend. The first, of course, is to review, I'd like to review the current recommendations that you all have pushed forward to date so that we can see what we have already for the report and continue to build on that. We will give a presentation on the analysis that we did for the Public Safety Subcommittee on what a retrofit of OSPM might look like to house a geriatric or special population. We also, I believe we have information on the cost of constructing a new facility as we looked at our 10-year, now 15-year construction plan. Junction City was to be a special population facility, so we could share the cost of that, but also include what positive outcomes or efficiencies we might have housing that population together in a Another agenda item will be what other states are doing with regard to the geriatric population and how many of those actually have constructed or are utilizing facilities solely for that purpose. And then if we have it complete, we will distribute the document that we're going to share with Pew that talks about the data errors that we found so far. Any other agenda items?
Yes, it would be helpful to actually expand on the work between the Oregon Health Authority and DOC on which would bring us into electronic records and how that whole 90-day suspension versus termination and OYA. I think that's a conversation and added that.
Great. So how it's working now, Senator, and what the future looks like.
What the future looks like, and you know, possibly what this work group may need to do to help facilitate.
We can add that, certainly. Any other agenda items? Director?
There was a conversation in the Pew report around older inmates and the significantly lower rate of recidivism. Naturally, this relates to sentencing guidelines, etc., but there was a recommendation, or perhaps I perceived that there was a recommendation, to look at the cost-benefit analysis of low-risk, higher-age offenders. And my understanding is some states are looking at that, and how would that help lower the cost of care, both health care and prison costs?
Senator?
And offline, if Bill can talk to me about that pharmaceutical that's almost $50,000, that maybe we can be helpful to see if we can't have some conversation.
Okay. I'll just speak briefly, Director, to your point, because we have looked at this before, but we'll certainly prepare a presentation for this work group. People age out of crime, as you know, when it comes to burglaries, property crimes, even many violent crimes. And the one area that they don't age out of are sex crimes, but their recidivism rate is incredibly low. And so I'm guessing that that low recidivism rate for that older population who were incarcerated for 25 years due to a sex crime probably is for that reason. But we're certainly, we should look at what other states are doing in terms of managing that risk and potentially releasing. Thank you. Sheriff?
I have a question, Chair, on, I appreciate your diligence in capturing recommendations, and then you said we need to build on them. I'm wondering if one of the ways to build on them is to begin to put cost or reductions in cost to those recommendations, since Senate Bill 843 gets down to dollars and cents at some point in time, and then it may have been provided, and my apologies if I overlooked what the current budgeted or expenditures amount is for DOC Health Services by, Mr. Hafel's departments, by medical, dental, behavioral health, and pharmacy, so we can, we have something to really put those reduced costs into context at some point in time. I think that would be really helpful. I know the train's moving fast.
It is moving fast. Thank you, Sheriff. I believe we provided that breakdown in the first presentation. The overall cost of our healthcare program is almost exactly what the state spends on community corrections. It's around $200 million. But I believe it's in the first presentation. We can draw it out again as part of our follow-up.
And
thank you.
It may be, you could have those two comparisons, but it may also help to look at how it compares with the overall population. Because and the Oregon Health Authority would have the stats of what it looks like for the general population. Okay. Particularly if we're talking, I would use the Medicaid population, because you're talking older, sicker, and some of those diseases would also pop up in their population. It might be well to look at those three and some comparison as to what it's basically costing us, particularly as a state, as we're moving to more of the CCO model, which is the managed care model. And you already have the third-party manager. It would be kind of interesting to see how they compare. And maybe even as we look at trend lines going forward, because certainly CCOs are going to be required to provide certain matrix and data to the legislature, and so we can then begin to kind of get a read on how well we're all doing in comparison to what.
Mr. Hafel, did you have something you wanted to add?
I could potentially answer part of your question. The World Health Organization.
Since we're on the record, if you can come to the microphone and introduce yourself again.
For the record, Bill Hafel, Health Services Administrator, Department of Corrections. World Health Organization and Health and Human Services did studies around healthcare costs in the United States for the year 2010. Health and Human Services, I believe, came out at like $8,401 per person in expenditures for the year. World Health Organization calculated it at $8,362, which comes out somewhere around $700 a month per person. For that same date range, the Department of Corrections was somewhere around $550 a month per person.
And I'm sure that the Oregon Health Authority has probably what their universe is. And the OIA has what their universe is.
So as follow-up, you would like those 2 data points plus OHA plus OIA and just do it side by
And
side?
just do it side by side.
Okay, great. We'll do that. Thank you, Mr. Haven.
And I don't know who keeps community corrections, but somewhere out there, you know, because they wanted to be a part of this discussion and problem. So somebody out there probably has community corrections too.
Thank you. Any other agenda items? Anything for the good of the order? The only thing that I will mention is I will draw your attention to the What Works Conference, which is an annual conference being housed up at the Convention Center in Portland. You will be receiving an invitation. It is an invite-only conference, and I will forward that invitation to you later today. It's sponsored by the local Lipsick. The reason you will all be getting an invitation is because the title is Leveraging Healthcare Transformation to Improve Behavioral Health and Public Safety Outcomes. About as timely as the Pew Report, I might note. Okay? All right. With that, I have kept my promise, and we are going to adjourn on time. Thanks, everyone, for your participation.
Thank
I
you.
appreciate it very much.